Okay. Whoops, I gotta move one thing. I got three screens now, so I got a bunch of stuff going on. Okay. Okay, so what I found is there's a rift, a split in the pandemic data. There are at least two distinct data sets, that of pre and post March 24th, 2020. This presentation is very condensed. It's basically an elevator pitch of my research. The main focus of this presentation is to show the movement away from clinical symptoms, which are infections, and towards cases. In all past epidemics, pandemics, and endemics, these two forms of pathologic measure shared a one-to-one relationship. So what's boosting these numbers? We see the pandemic started in 2018 and it's been going, and it went on for about a year and a half. And then all of a sudden at March 24th, 2020, we see a spike. So this graph is centered on the flu season in 2019, 2020. That's the center of the graph, is the flu season. And you see this pink line, something happened here. The deaths from underlying cases of COVID spiked and all-cause spiked. So what happened here? What caused this? It wasn't the variants, because those don't happen until in September, December of 2020, which is not even on this chart. So something happened here. The virus didn't change. What changed? After some research, I found out that we implemented a lot of policies around this time period. March 20th and then 24th were just to start it off. The NVSS, the National Vital Statistics System, through the WHO, released a new ICD code, which is the International Classification of Disease Code, U07.1, which is how you record deaths. This is the ICD code. And now COVID has its own designation, which is that U07.1. That started on March 24th. And soon after that, and when all these others were implemented, we saw a huge jump in deaths, all causes of deaths and COVID deaths. So that led me to my question, what are these policies doing? If these policies are impacting them, how are they impacting them? And this is Shijin Lin. This is one of the most important virologists in the pandemic. And she's super famous. And if you haven't heard of her, that means a lot of the pandemic is still unknown to you. And she's wearing the only amount of PPE that is effective against an mRNA virus. Any other amount of PPE than this is non-effective. This is Shijin Lin, the Bat Lady of Wuhan. So we're going to jump into the data. We're going to get rid of the corporate media and their hysteria and all social media and their fear porn. And what we're going to do is just focus on the data. And according to the data, in the last 4 years, the population of America was not decimated. And on top of that, the population in America did not decrease. And to go even further, the population in America in the last 4 years grew and grew at normal levels, at expected levels. So what that means is that there was nothing in the last 4 years, no event that happened that created a negative impact on the population. And to say that another way, according to the data, there was no pandemic. So you see this big number in jumps and deaths in 2020. So in 2019, 2018, 2019, we have no jumps in deaths. And then right around 2020, when we implemented all these new policies, we have a huge jump in death. And I believe I'm able to link this jump in death to about 6 states that implemented specific COVID policies. So we have all these COVID deaths jumping, but the overall number of deaths isn't jumping that much. So that's something I call classification capture, to where the total amount of all other diseases is decreasing almost exactly. The number of COVID deaths is rising. And that happened after March 24th, the beginning of April, mid-April, all the diseases decreased, this exact number COVID increased. And then late April, we're doing it again. 3 weeks in a row, this is happening. And I was like, why? First off, this is making our data less accurate. If we wanted to come back and look at, SARS-CoV-2 impact on specific diseases, we can't, because they're all labeled COVID deaths now. So why would we want to pile all of our diseases into one category? Well, one thing I came up with is the government pays for COVID deaths. So the government pays states like Minnesota, Nebraska, and Montana $300,000 for a reported case. And remember that WHO and all of them are changing their definitions of what a case is to make it really wide, really vague. So now you can see that it's more important it's more cost effective. Your hospital makes more money if all your deaths start getting classified as COVID deaths. So in this one hospital, in this one room, in this one city, in this one state, at this one moment, that's $5 million right there. Not based on being sick, but based on a test. Because what we're going to see is that they're changing they're going away from infections and going towards cases. So you see New York, they're only making $12,000 per case. That's not a lot. So you see that people in New York, according to the government, are worth less than people in rural cities. So I wonder why the government thinks that. Somebody should look into that. But what New York did, they had their own unique take on science. So they broke precedent again. We have established SOPs, standard operating procedures, and everything. But instead, we're going to do the opposite of that. And what we're going to do is take young, otherwise healthy COVID-infected patients and make them cohabitate in nursing homes with the elderly and the immunocompromised. So what New York did was take young, otherwise healthy individuals who got infected with COVID that have a 99.998 survivability rate and put them in with our most vulnerable populations. And on top of that, they prohibited the nursing home staff from testing these individuals. So you have our most vulnerable populations in with confirmed COVID patients, and you're prohibited from testing. That's New York's answer to this pandemic. And you see the impact of this is that number earlier, the extra 500,000 deaths, because Michigan did this and 4 other states did this. And a lot of them are getting litigated now for covering up the numbers. But so this is a huge spike in the death. Tens of thousands of elderly and immunocompromised nursing home residents died because of this. So now we see on March 24th, this is the beginning of the divorce from precedent, from all our other ways of responding to pandemics in the past. And since medical history began, we're going to break precedent now and do something different. We're not going to treat the sick. We're going to treat everybody with this test. So there's a test that is it's a divine test for some reason. We're basing everything on the pandemic on this test. So now we're completely divorced from infections per the WHO. So what is this test? It's the PCR test, and it's completely manipulatable. You could, if you want the more percentage of tests to be positive, there's a thing called the threshold cycle. So the CT, you set that to 40 and above, a large majority of your tests, because of your amplification cycles, are going to be positive. You want to bring that back down to most of them being negative, you drop it down to 25, 15. So the only way we know the pandemic exists now, because we're not looking at the sick people, the infected people anymore, we're looking exclusively at this test. And that's the only way we know that the pandemic exists. So if we put the threshold up higher, then more cases, then since the policies, the governmental policies, and the incentivization through money from the government is all based on case number, which is based on the PCR test, it's in the hospital's favor to boost the CT, because then you get every positive PCR test is $300,000. So there's no reason for them to put it down past 40, the cycle threshold. And so now the WHO is pushing this asymptomatic spread. So, and the CSTE, which is the Council of State and Territorial Epidemiologists, they're also pushing this asymptomatic spread. So, and so they need some science to back it up, because this is what they're pushing, is that people that are healthy, that are running, that are exercising, that are so healthy, they're the ones that are actually sick. And they need some science to back this up. So what they did is they got JAMA to write a report, the Journal of American Medical Association, and so because they wanted some scientific clout, some doctors to say, hey, that's right, we're all asymptomatic. But they didn't peer review it. They said, no, thank you, other scientists, do not review our work. We don't need you to review our work. We're right, just trust us, trust our science. They had no participants. They had math assumptions only. They scribbled some models down on some paper, and they came up with 60% of these healthy individuals are spreading asymptomatic. And then you boost that through that, all you need is the PCR test with the high cycle threshold. So that's backing these guys up. So that's not science. That cannot be construed as science at all. So what Wuhan did, they had some science. They had peer reviewed, because you always question the science. You don't trust the science. You get other people to validate you or say you're wrong and figure out why. And they had 10 million enrolled. So these guys did science, and they came up with 0% transmitters. So that's where I'm going to end this, but just to show you that there is a move towards a narrative towards asymptomatic spread where there's no evidence that it exists. And there's also a lot of evidence that says it doesn't exist. So that's where I'm going to stop for now. What do you guys think?
Chris, you are extremely articulate.
Is it good? Okay. I have to go